Thank you. So I apologize. I'm going to have to run through this because I'm going to be late. You've heard a lot this morning about the mechanical ventilator and how we can use the ventilator to protect the lung. I'm going to present another paradigm, which is using sedation to protect the lung. And the interaction between our sedation and our ventilator is not something that we think about. And I'd like to thank my colleagues Jeremy Beitler and Elias Beidorf-Cassis who've helped me think through this paradigm. So this is a common occurrence in the ICU. This is a 48-year-old patient with COVID, deeply sedated, RAS of 5, so basically comatose. But you can see on the ventilator that this patient has frequent reverse triggering with breath stacking. That breath stacking is going to lead to high tidal volumes and high transpulmonary pressures. And this patient is injuring their lung in spite of being apparently completely sedated. We know that deep sedation is common in the ICU and it may cause harm. This is highly confounded data, but it's showing that our patients with ARDS who have deep sedation are at higher risk of death, and that it's directly related to their RAS score. So if you have a lower RAS score, you're more likely to die. Of course, if you're sicker, you're more likely to be sedated. You're more likely to be heavily sedated. So it is confounded data, but just throwing sedation on patients may be doing them harm. And this got worse during COVID, and this is data from our ICU. If you look here, these are the patients who are arousable or awake. These are the extubated patients down there. These are the patients who are comatose. This was non-COVID prior to COVID ARDS patients. And over here you can see that the COVID patients were kept heavily sedated. And at least in my experience, that was often due to the perception that they were overbreathing the ventilator, had high respiratory drive, and were at risk for patient self-induced lung injury. So our typical solution in the ICU has been throw sedation on the patients to try to keep them in sync. But really we need to balance our lung protection and harm by sedation. Sedation is helpful to prevent villi through self-inflicted lung injury, but if sedation is harmful to the diaphragm, it can lead to prolonged intubation and death. So what is lung protective sedation? It's targeted sedation with personalized goals for each patient. We have to define the specific sedation effects, harmful versus tolerable effects, harmful versus tolerable dyssynchrony, and we really don't know enough about dyssynchrony to know which is harmful and tolerable, and we need to improve our monitoring. Specific goals for lung protective sedation would include allowing the patient to tolerate uncomfortable settings, so higher PEEP, lower tidal volume, not comfortable for the patients. That can lead to struggling on the ventilator, so we need to sedate the patient to allow them to tolerate those settings. We need to limit self-inflicted lung injury, and this is the vicious cycle where patients begin to overbreathe. Their increased respiratory drive leads them to overbreathe, breath stacking, and the high transpulmonary pressures and high volumes associated with that lead to further injury. And that's made worse in a sick patient because, as you can see down here, I'm not sure you're seeing it, but you can see that the solid-like behavior of injured lung can actually exacerbate the effects of spontaneous breathing. So we need to prevent injurious dyssynchrony. So here's a patient with reverse triggering. That can lead to increased ICU stay and mortality. That's been shown in several papers through large pleural pressure swings, large tidal volumes, increased respiratory muscle work, increased sedation needs to try to remove it. So we need to try to prevent that injurious dyssynchrony through our sedation. And finally, sedation itself may lead to a reduction in lung inflammation and the acuity of the ARDS, either due to reduction in P-cili and dyssynchrony or direct effects of the sedatives. So how do we measure the effect of sedation on effort and dyssynchrony? These are the two most commonly used sedation scores right now, the RAS score and the SAS score. Really, they say nothing about ventilation. So So in the RAS score, +2 includes obvious fighting the ventilator, whatever that means. But there's nothing else in here about synchrony with the ventilator or the effects of the sedation on the patient's interaction with the ventilator. So really, these scores are inadequate. They're designed to measure level of consciousness. We use them perhaps to prevent post-ICU delirium and mental deterioration, but they are inadequate for measuring what we do on the ventilator. RAS and effort, so high RAS actually is associated almost with increased effort as measured by the P0.1. Most patients who were either too awake or too asleep had high P0.1s. There seemed to be a sweet spot in the middle, but this is a very small sample size. So RAS is a very poor indicator of patient effort. This shows ineffective triggering. Again, increased sedation seemed to be associated with more ineffective triggering, another type of dyssynchrony. So the sedation scales really don't work. This is reverse triggering. Again, we can see that commonly in patients with ARDS, and it may be unmasked by sedation. So higher levels of sedation could lead to increased levels of reverse triggering. Not all sedatives are necessarily bad, so this is an interesting study which looked at the effects of sedatives, opioids, and the combination of sedatives plus opioids. And what they found is that sedatives don't decrease the asynchrony index, so they don't limit asynchrony. The drug that really does a much better job of that is opiates. So suggesting that maybe as a sedation strategy for patients who are mechanically ventilated, we move to a higher opiate strategy rather than using other drugs. This study looked at propofol and dyssynchrony. Really, they were looking at the effects between two separate ventilator modes, PSV and NAVA. But they found that deep sedation with propofol was associated with a higher incidence of ineffective triggering. So again, higher sedation, not necessarily better in our ventilated patients to protect the lung. We need to develop a new paradigm of lung protective sedation. This is another study that showed that dexmedetomidine might be better than propofol, although it was a relatively small sample size. They used EADI to calculate an asynchrony index, and dexmedetomidine was better than propofol in this study. A final study I'll show is another one associating the depth of sedation and dyssynchrony. They looked at double triggering and flow-limited breaths, and dyssynchrony was reduced overall by deep sedation, but they still saw high tidal volumes due to dyssynchrony in the high levels of sedation. So overall, the signal I'm trying to show you here is that our current methods of sedating patients are ineffective at predictably limiting the patient's adverse interactions with the ventilator. What may be better? So here we can see this is breath stacking index. They looked at no intervention. So if you did no intervention, there was no change in the breath stacking index. Sedation was ineffective at reducing the breath stacking index, but changing the ventilator settings rather than increasing the sedation was effective. Are there other options beyond our standard armamentarium of sedatives? So we saw that opiates may be better than propofol, dexmedetomidine may be better than propofol, but are there other options out there? And this is a study we did looking at the effects of ketamine on the work of breathing. We found that ketamine reduced the resistive work of breathing quite predictably. So is ketamine a more appropriate ICU sedative than what we're using today? Volatile anesthetics, there's a lot of interest in literature in this. They have direct anti-inflammatory effects on the lung. They provide reliable sedation, and they're available in our ICUs today. Volatile anesthetics began use in the ICU for bronchodilation in acute asthma. Very commonly used in children, less commonly used in adults due to the technical difficulties. But they will reduce the peak inspiratory pressure, improve gas exchange, and improve airflow through their bronchodilation. They appear to have direct lung protective effects. So this is a study of 200 surgical ICU patients showing an increase in the probability of survival with isoflurane versus propofol as sedatives. So that direct effect on the lung may actually be protective. And this is another study around the same time. There's several other large studies out there comparing sevoflurane and midazolam. Sevoflurane was associated with a reduction in S-rage and trend towards an improvement in the duration of mechanical ventilation. So we need to open our eyes and look for other alternatives to our traditional propofol sedation. And we need to find better ways of monitoring. As I said, the RAS score and the SAS score are totally inappropriate for monitoring the ventilator interaction. This is one option. These are Campbell diagrams of the lung showing and classifying dyssynchronies with the ventilator. And we can eliminate those with our sedation or with neuromuscular blockade. So a better understanding of the types of dyssynchronies out there may allow us to focus our sedation in a more appropriate manner, because there are injurious dyssynchronies and there are more benign dyssynchronies. We can measure effort using EADI or using the pressure time product. Both of these require special catheters, so they might not be applicable in all ICUs. But most ventilators now will measure a P0.1, which is a very good indicator of patient effort during spontaneous breathing. It's an automated measurement in most ventilators. Now, there's some concern that it might not be entirely accurate in some modes of ventilation and on some ventilators, but that's a technical problem we can improve. And it's also something that if it works, then it works, not necessarily need to be 100% accurate. As I said, there's no direct correlation, you saw this slide before, between P0.1 and sedation, meaning that we're going to have to find better ways of sedating patients because our current methods won't reliably reduce effort on dyssynchrony. So getting back to that case, this is the case that I showed you at the beginning. In this patient who had a RAS of -5, we actually had to reduce sedation to eliminate the reverse triggering and breath stacking. So the answer, typically in the ICU is always more sedation. More sedation, sometimes the answer is less. We need to be looking and thinking about the interaction between sedation and the ventilator. So lung protective sedation, a new concept. We need a better understanding of which breathing patterns are harmful versus benign. We still don't know that. We need to be able to monitor sedation to target lung protection and not the level of consciousness. We need to assure fully passive breathing in the very sickest of patients. We need to use sedatives to optimize and eliminate dyssynchrony. And we need to target safe levels when it's appropriate for the patient to be breathing spontaneously. So, we need to figure out how we can sedate and keep the patient comfortable, but allow them to breathe spontaneously and protect their diaphragm. Better understanding of specific sedatives. So I showed you some of the literature. That's basically all the literature, by the way. There's not a lot out there talking about the specific sedative effects on the respiratory system. Future use of non-standard ICU sedatives. I think that inhaled anesthetics do have a lot of promise in this field. We need to balance the lung and the diaphragm, and there are possible metrics for measuring effort would be P0.1, respiratory rate, and delivered tidal volume, all of which we already have today. But those are just the simple, easy ones. So I'd like you all to go home and think about this, to keep looking at your ventilator, at your patient, thinking about how to sedate the patient in a better way. Thank you very much.